Welcome back to the deep dive. I want you to think for a moment about your skin. It's this incredible fortress, really, keeping all the good stuff in and, well, all the bad stuff out.
It's the ultimate barrier.
Exactly. But what happens when that fortress wall is just structurally compromised from the start? When the foundation is weak and the gate is always a little bit open.
That's a perfect analogy.
It's the reality for millions of people dealing with atopic dermatitis. And you provided us with some fantastic sources on this chronic condition. So our mission today is to go deep. We want to get past that generic word eczema and really understand the genetics, the immune response,
And the environmental factors, yeah.
and most importantly, pull out the best strategies for managing it. Okay, let's unpack this.
And, that distinction you just made is the perfect place to start. The whole eczema versus atopic dermatitis thing.
Right.
Eczema is really just this big umbrella term. It can mean anything from, say, contact dermatitis you get from a new soap.
Or like dandruff, seborrheic dermatitis.
Exactly. But atopic dermatitis, or AD, is a very specific type. It's the most common form, sure, but it's not just a skin reaction. It's a chronic condition tied to a systemic allergic hypersensitivity.
So it's a whole body issue that's just showing up on the skin.
That's the key. It expresses itself through the skin.
So if we're defining AD, the sources describe it as a chronic inflammatory condition. You get intense itching, really persistent dryness, and these rashes that just flare up and then recede.
Constantly.
And it usually starts in childhood, but it can absolutely stick around for life or even, show up for the first time when you're an adult.
And it almost never shows up alone. That's another critical piece. If you have AD, it's very, very likely that you or your close family have what's called the atopic triad.
The triad being
Eczema, asthma, and allergic rhinitis.
hay fever.
Right, hay fever. If a doctor sees 2 or 3 of those in a family history, it's a huge red flag for a systemic, inherited tendency toward allergic overreactions.
Your body is just hardwired to freak out over things that should be harmless.
Perfectly put.
Okay, here's where it gets really interesting, and this is the core biological piece you need to understand. The filigrin factor. This word was everywhere in the sources. Can you break down why this one protein is so critical?
Absolutely. The problem really does begin at the genetic level in the actual architecture of the skin.
The architecture.
Yeah. Filigrin is short for filament aggregating protein. Think of your skin cells like bricks. Filigrin is the mortar holding them all together. It creates that strong, protective outer layer.
Okay, so it's the glue.
It's the glue. And studies show that up to half of all people with moderate to severe AD have mutations in the gene that makes filigrin. So you don't have enough of it.
And the mortar is built?
It's weak, it's porous. And that means 2 things are happening at the same time. First, moisture just evaporates right out of your skin. That causes the chronic dryness, what we call xerosis.
And second?
Second, and this is the big one, all the things that are supposed to stay out. Irritants, allergens, germs, they just walk right in.
So the skin is basically sending out a constant SOS to the immune system.
Exactly, and it's a very specific kind of SOS. This is where the skin breach connects to the systemic problem. When those allergens get in, they trigger what's called a Th2 dominant immune response.
Now that's a term that gets thrown around a lot. What does the H2 dominant actually mean for the person experiencing it?
Okay, so think of your immune system as having like different branches in the military. The Th2 branch is the one that's specialized to fight big external parasites, which is also why it handles allergic reactions. In AD, this system is just miscalibrated. It's like a fire alarm that goes off every time a dust bunny floats by.
And that constant unnecessary alarm is the inflammation and the itch.
That's the chronic inflammation. And we can actually see proof of this in your blood work. The sources point to elevated serum IgE levels and eosinophilia.
Okay, what are those?
IgE are antibodies your body makes for allergic reactions. If they're high, your body's in full-on allergy mode. And eosinophils are a type of white blood cell that fights allergens. High counts of both are biological proof that this isn't just a simple rash. It's a systemic allergic process.
And as if that's not enough, there's the whole microbial side of things. What happens on the surface of that broken barrier?
Well, that broken, inflamed skin is basically a buffet for bacteria.
Right.
And the research is really clear on this. The skin becomes super susceptible to colonization by one bacteria in particular, Staphylococcus aureus. Up to 90% of AD lesions can be colonized with it.
And that makes everything worse.
So much worse. Staph produces toxins that damage the barrier even more, which creates this horrible vicious cycle. The skin breaks down, bacteria get in, bacteria cause more damage, which causes more inflammation.
Which causes more itching, which makes you scratch, which breaks the barrier down further.
You got it. It just feeds itself.
Let's talk scope, because these numbers are huge. We're looking at 10 to 20% of all children.
And 2 to 10% of adults. That's something like 16.5 million adults just in the U.S.
And it's not just a mild issue. A third of those people have moderate to severe symptoms that really, truly impact their lives.
Yeah, and you also see this environmental link.
Mm.
People in cities have higher rates, more pollution, lower humidity, more allergens. It all conspires with your genes.
And the sources made a really critical demographic point, that African American children have both a higher prevalence and more severe symptoms than white children.
That's a crucial point, especially when we talk about what it actually looks like.
The visual presentation.
Exactly. On lighter skin, we see that classic red rash. But we have to know that's not what it looks like for everyone.
Okay.
On deeper skin tones, the inflammation often shows up as dark brown, purple, or even gray patches. A clinician who is only looking for redness might miss the diagnosis completely.
And that relentless cycle of itching and scratching, it leaves permanent marks.
It does. We see something called lashenification.
The skin gets leathery.
Thick and leathery. Yeah, from years of scratching. You also see oozing lesions during bad flare-ups. But, the impact goes so much deeper than the skin. The itching disrupts sleep, which affects your mood, your work.
Your whole quality of life. I can see how that would lead to real emotional distress, even social withdrawal.
Absolutely. Especially for teenagers and young adults.
Okay, so that brings us to managing it. Since we can't change the genetics, the filigree issue, managing the external world seems like the most powerful thing we can do.
That's where you have the most leverage. We have to systematically identify and avoid the triggers.
Right. So let's list them out. First up, irritants.
Harsh soaps, detergents. They contain surfactants that literally strip away the natural oils your skin desperately needs. Fragrances and preservatives in cosmetics are another big one.
And then you have the actual allergens getting through that faulty barrier.
Yep, the classics. Dust mites, pet dander, pollen. They don't just cause sneezing, they get right into the skin and fire up that Th2 response we talked about.
What about physical triggers?
Huge. Sweat is a major one. The salt is very irritating, and it messes with the skin's pH balance.
So exercising can cause a flare-up.
It can be a real challenge.
Yeah.
Also, low humidity, cold weather, indoor heating, AC, it all just pulls moisture right out of the skin. And finally, pollution. Things like cigarette smoke and airborne pollutants directly trigger the immune system on contact.
Given all of that, the genetics, the immune system, the triggers, how does a doctor actually put all those pieces together to say, yes, this is atopic dermatitis?
It's mostly a clinical diagnosis. It starts with a really detailed history, looking for that atopic triad in the family, then the physical exam, looking for the dryness, the lichenification.
And then to back that up.
You can run blood tests to confirm the systemic part of it. That's where you look for the high serum IgE levels and the eosinophilia. If you see those, you know this isn't just a simple contact rash. The whole system is involved.
Okay, diagnosis is in. Now, treatment. Let's start with the medical tools that are used to calm down that aggressive immune response.
The first line is usually topical corticosteroids. They're powerful anti-inflammatories. They shut down that immune hyperactivity and reduce the redness, the swelling, the itch pretty quickly.
But there's a downside. The sources were clear about that.
There is. Long-term use of strong steroids can thin the skin, which is called atrophy. And that can actually make the barrier problem worse in the long run.
So what are the alternatives?
A key one is calcineurin inhibitors. These are non-steroidal creams that work differently. They block a specific part of that T-cell activation in the Th2 response. They're great for delicate spots like the face or eyelids, where thinning is a big concern.
And what if it's really widespread and severe?
For those cases, you might use light therapy or phototherapy. It's controlled exposure to UV light under a doctor's care, and it helps reduce the immune activity in the skin.
Now let's shift to the daily work, the maintenance. This is really the heart of prevention, right? The philosophy of barrier restoration.
It is everything. The core idea is simple. You have to manually put back the moisture and oils that your skin can't hold on to by itself. That means daily, liberal use of emollients.
High-quality moisturizer.
Yes, ones that are rich in lipids to lock in that hydration. And your hygiene routine is non-negotiable. Gentle cleansing, no hot water, no scrubbing.
And there was one step that the sources called out as being absolutely critical.
The 3-minute rule.
The 3-minute rule.
You pat your skin dry right after a bath or shower, and apply your moisturizer within 3 minutes. That's the golden window when your skin is still full of water.
Hmm.
The moisturizer acts like a seal and locks it in. If you wait, it just evaporates.
And then we get into diet, which the sources also touched on.
Yeah, for some people, eliminating known food allergens, dairy, eggs, gluten, can make a real difference in systemic inflammation. But you have to do that with a dietitian to make sure you're not missing key nutrients.
Now, you provided some really interesting specifics on products and ingredients designed for this. I think it's helpful to connect these directly to the mechanisms we've been talking about.
That's a great idea.
Yeah.
Because the products are trying to solve those two main problems: repair the barrier and reduce the bacterial load.
Okay, let's start with the bacteria. One source mentioned a hypochlorous acid spray. What is that, and how does it help?
So, hypochlorous acid sounds intense, but it's actually something our own immune cells produce to kill germs.
Oh, wow. Okay.
So a spray like that is a very gentle but effective antimicrobial. Since AD skin is so prone to staph colonization, it's a way to reduce that bacterial load without using harsh drying alcohol. It helps break that vicious cycle we talked about.
Then we have the barrier repair creams. We see ingredients like colloidal oatmeal, calendula, shea butter. What are they each doing?
They're doing two things: soothing and repairing. Colloidal oatmeal is a skin protectant. It forms a physical barrier and helps with the itching. Shea butter is rich in lipids, so it's literally acting as a replacement for the mortar that's missing because of the filigree defect.
And what about those products with a whole list of botanicals, like the Elixir 16-in-1 cream, things like aloe, chamomile?
The goal there is usually twofold. You get the calming, anti-inflammatory effect from ingredients like chamomile, and then you get humectants from others, ingredients that draw water into the skin to boost hydration from within that compromised barrier.
And finally, even how you wash your face needs to change. The sources recommend sulfate-free, pH-balanced cleansers.
This is probably the most overlooked part. The goal of cleansing for AD is to clean without stripping. Sulfates are those harsh detergents we talked about. Using a cleanser with things like manuka honey or sunflower oil means you're cleaning gently and also depositing restorative oils back onto the skin, not washing them all away.
So the big takeaway here is that a consistent, targeted skincare routine isn't just for comfort, it's a clinical intervention.
Precisely. You are directly addressing the core problems. By strengthening that barrier and managing the microbes, you break the cycle. That daily maintenance is what keeps you in remission and reduces the need for stronger drugs. It's what improves your quality of life.
So what does this all mean? Atopic dermatitis is a complex, it's chronic, and it is absolutely not contagious. Its roots are genetic, that filaggrin protein failure, which kicks off a systemic immune overreaction. Management has to be a multi-pronged attack: daily barrier repair, gentle hygiene, and just meticulous avoidance of your personal triggers.
And that leads us to a final thought for you to consider.
Yeah.
We've talked a lot about the physical burden, the pain, the itch, the lost sleep. But the sources also specifically call out the psychological distress, the embarrassment, the anxiety, the social withdrawal. So, given that this is a genetic condition, and given that it is fundamentally not contagious, how might greater public education about its true nature help alleviate that huge psychological and social burden for the millions of people living with it? It's a fight against your own skin, but it's also a fight against perception.
A really important question to think about. The physical battle is one thing, but the social stigma is a burden no one should have to carry. Thank you for sharing your sources and your time with us. We'll catch you next time for another deep dive.